Hello and welcome to another episode of Keeping London Healthy. I'm Dr. Mario Elia. So last month, you'll remember we brought on a urologist to talk about prostate health and prostate cancer screening. So I thought it was appropriate come this month that we're going to switch gears and talk about women's health and specifically breast cancer, breast health, breast cancer screening with Dr. Muriel Brackstone. She's a general surgeon here in London and a breast surgical oncologist. So treats breast cancer and deals with women related to breast concerns. So after this message, we're going to be speaking with Dr. Braxton. All right, welcome back. Again, we're really pleased to be joined today by Dr. Muriel Brackstone. So Dr. Brackstone is a general surgeon. She's the citywide chair chief of general surgery. She's a professor at Western University, and she's the founding medical director of the breast clinic at St. Joe's, and she's a breast surgical oncologist. So really excited to have her speak to us today about everything related to breasts and breast cancer. So thanks again for joining us today, Dr. Brackstone.
My pleasure.
So let's start off just with some basic questions, even around, prevalence. So what proportion of women do we expect to have breast cancer in their lifetime? Like how common is this?
So in general, we say 1 in 8 women will develop breast cancer in their lifetime to the age of 80. So that's approximately a 13% risk over your lifetime.
And one of the more common questions we get for women who are, maybe concerned about their own personal risk because of experience that they've had or family history, or what kind of things can they do to reduce the risk of cancer. So we'll start off with that. Any things that women can do to reduce the risk?
Yeah, I mean, probably the biggest risk is the family history, and there's not a lot you can do about that, except if your family history is really strong, then you can go get some genetic testing, which looks to see if you're carrying a gene mutation that puts you at higher risk, and then there are preventative treatments for those situations. But in general terms, for average risk women, reducing excess weight, so carrying an ideal body weight, reduces the amount of circulating estrogen. We think there's a slight increased risk after menopause in taking hormonal supplements, particularly combination estrogen, progesterone. But in general terms, we haven't seen an increased risk with oral contraceptives, possibly reducing excess alcohol consumption, and that might tie into body weight as well, more than 1 or 2 drinks a day on a regular basis. Those are the general risks that we look for.
Common question we get is in terms of screening. So women without symptoms who are interested in perhaps early detection and staying on top of that. And I know there's been some controversies over the years in terms of when to start screening, when to stop screening, how often to do screening. So can you tell us a bit about kind of where we've come in terms of kind of the screening question and kind of how we approach screening, and then if there's been any recent changes in terms of screening?
So the best screening tool we have is still the mammogram. So the mammogram is a low-dose X-ray of the breast in 2 directions, and that's a really useful screen for any changes that might require additional tests. So by itself, if there's a problem, it's not enough to say yes or no that everything is okay, but it's a great screening tool. And so we had started it after menopause, really thinking that before menopause, women's breasts are really dense. It's really hard to see through, and it doesn't give you maybe as accurate a screen. And so in general terms, since most women go through menopause on average 50, 51, we started screening from 50 and older. And in that situation, every year initially was a screening. We moved to every other year, and we weren't really convinced that we were making that much of an impact. There was a lot of concern raised with regards to moving the date to an earlier age. That's what's happening in the States and has been for many years. And so that's really the only thing I would say that is new with regards to mammogram, is that we're dropping the age as of next fall, I believe, that screening will now start at an earlier age. That's not to say that you can't have a mammogram at any age as appropriate after a discussion with your family doctor. But in terms of self-referral and general screening, we're going to be moving still every other year for average risk women, starting at the age of 40. Anyone with a first degree family history or slight increased risk, we're typically doing it once a year.
And then in terms of when to stop screening, this is a conversation we have with women as they approach 75. Do we keep screening them? Do we not? What are some things to kind of consider for those women?
It's really hard to know when to stop screening. When we have women that do carry a gene mutation or are really high risk, we add an MRI to the mammogram once a year, and we start that at age 30 to be young enough to capture what we think most of the cancers, and we stop that at age 69. thinking that by then you were going to fall more into an average risk category. And the average risk mammograms typically we're stopping at 75, but it really is shared decision making with your family doctor who knows you best, and looking at what are the other health issues that you have. And if you have a lot of other health issues, it's unlikely that even a breast cancer that you get is going to have a significant impact on your survival, how long you live or how well you live. And if that's the case, then it's probably not worth continuing with the mammograms. Or if you have a lot of mobility and it's hard to get to, if there are a lot of issues that really impact your ability to have this screen in a reasonable way, it's probably not worth doing. But if you're otherwise well and you're expected to live another 10 or more years, it's probably worth doing a mammogram moving forward beyond the age of 75. So that's a really important discussion to have with your family doctor.
For breast density, you mentioned it a bit earlier, and this is something that we're seeing on reports now being described, whether someone has dense breasts, and there's a rating system that we see on reports. Should women be asking about breast density? Should that be triggering them to be asking their practitioner for additional imaging? I know it kind of depends on where people live, but what should women know about their breast density?
We still are learning a lot about the impact of breast density on risk. We initially felt that when the breast density is reported as dense or extremely dense, we're not getting as good a screen. So your screening tool is less effective. But we didn't know really, we didn't appreciate that it also carried with it an increased risk, independent of our reduced ability to see a cancer developing. It also seems to be independently related to a slight increased risk of developing breast cancer. And that's where the governing resource have recommended that it become reported in the actual mammogram report, and that patients should be aware. What we do about it is still a challenge. In general terms, we have felt that if you have dense or extremely dense breasts and you're on average risk, increasing the frequency is going to overcome the challenges with regards to reduced sensitivity. And so probably instead of every other year, you should have a mammogram every year. There's some thought that maybe we should add something else, like an ultrasound, some other tool, but currently in Ontario, additional tests like that aren't funded. They're not well validated, and we're not sure how useful that is. So right now, increasing the frequency seems to be the best solution.
Only a few in my practice who refuse to get mammograms because of some experiences they've had in the past, with the mammogram being quite uncomfortable. Can you tell us a bit about how the technology has changed over time, and what their experience might be now compared to in years past?
I see a lot of patients also who have the concern, one with regards to X-ray exposure. And so I think it's important to appreciate which tissue is being exposed to radiation, because across our body, different parts of our body are more sensitive to radiation or can suffer damage from radiation than other parts. And there hasn't been any demonstrated evidence of increased risk when the radiation is to the breast tissue. So it's caught between the plates of the area giving the radiation and the area receiving the radiation. And when you look at patients that have had mammograms versus those who have not, the cohort of women who've had mammograms have an improved survival, cancer-specific survival. And so we have not seen it translating to an increased risk of cancer, or something that we traditionally think of from a radiation perspective. And so we feel that it's safe, and it's certainly the safest way to optimize your chance of catching a cancer early and not succumbing from that disease. There are some things that we've done to help with the mammograms. Probably the most effective is the more modern machines that have a rounded plate. So anyone who's had a mammogram, they lift your breast, lean it on a table, squish you forward, and compress the breast. And when the table that you're leaning on is rounded, it's not as uncomfortable. The other thing that most of the modern machines now have is a self-compressing dial. And so you can actually turn and compress and control your own rate of compression and amount of compression. And what's interesting is that women who do that probably actually compress even more than when it's done to you, because you have control over how quickly you can anticipate it, you can control it, and it's a lot more comfortable. And so I would really encourage women who've had bad experiences to try it again, particularly at a high volume center where they have the self-compressing device, and you can ask for that. But I think that it's really important to identify that some of the precancerous changes you're not going to see even on other better modalities such as MRI or ultrasound like you can on a mammogram. So to not do it, you're missing out on some opportunities for screening.
A few years ago, we had a number of patients go for thermography, which I know, and doesn't seem to be as talked about now as it was before. I've obviously told my patients that it's completely bogus, but I want to hear from an expert too, just to kind of reinforce your views on kind of thermography.
Yep, I've had that conversation a lot of times as well. And I think that scientifically, it's an interesting idea that the notion that increased blood flow will come to an area of disease. And while I think that's true for invasive cancers, so the thought is you're going to have more blood flow because you develop more vessels. And so while that's true for invasive cancers, I don't believe that to be true for non-invasive disease, which is the stage at which you want to catch something. If you're waiting for it to what we call neovascularize, grow its own blood supply to enrich itself and advantage the cancer to grow, you're probably waiting too long. And so I think that thermography has an interesting scientific role, maybe in monitoring the change of disease, but it's not proven useful. And I've certainly not seen it detect any precancers or have any clinical impact in the patients that I've seen who have had thermography with or without mammogram. And I think the best evidence is that is even in the report, the thermography report will say this is validated in conjunction with standard screening such as mammogram and should not replace standard screening.
Reminder to women out there again. So if you're an average risk woman, so again, no first degree relatives with history of breast cancer. If it's been over 2 years since your last mammogram, and you're between 50 and 75 now, and soon to be 40 to 75, please reach out to the Ontario Breast Screening Program and get that mammogram. Super important. I know a number of women have fallen behind with COVID and not kind of in the same routine, so it's super important. Question for you, and this is kind of from my own knowledge too. How would you say the proportion of women who are presenting to you with breast cancer that have detected themselves versus picked up on screening? Do you have any idea? Like, obviously not exact numbers.
I do see a lot of younger women in my practice, so I'm probably a little bit skewed. I
Sure.
would say the majority of younger women, so 30s, 40s, 50s, are detecting the cancer themselves.
Okay.
And I think the smaller ones that we see in screened patients in their 60s and 70s, those ones that tend to be mammography detected. I don't see very often very small cancers in women in their 40s and 50s yet, but I'm hoping that'll change with increased screening.
Yeah. And in terms of self-screening, I know this has been something that's kind of bounced back and forth, whether we recommend it, whether we don't recommend it. What's your kind of boilerplate answer to women who ask, should they be checking their own breasts and how often and how?
Yeah. I mean, I still don't really know. I think that it creates a lot of anxiety. And I think that women are nodular. And I think the best thing that we can tell women is you're lumpy bumpy. That's the norm. And so that's okay. If you're feeling lumps all over the place, that's okay. It's not for you to pick one lump over another one. But if you're familiar with the texture of your breast tissue, and maybe you should feel that gland once a month, something like that, after your period is done and you're at the least cysty that your breast tissue will be, that's probably useful. And so then if there's an obvious change, you're going to be the first to notice it. I think that's the safest way to do it. But to find a new lump over another lump, that's pretty normal.
So let's talk about if a woman does do a self-exam and finds a lump that they think, oh, this wasn't there before, doesn't feel right. What should they be doing? What should the first steps be?
I think the most important thing to do is to reach out to your family doctor. And it's really helpful to have, I mean, people who are blessed with a family physician who knows them well. That's going to be the most useful thing you can do. And oftentimes what I've seen them do is come in for an exam and maybe come in again a few weeks later if you're still menstruating because you're off cycle and things may change. So there might be some swelling and settling, cystic changes that might completely resolve over a cycle. But if they don't, it needs to be investigated further. And I think a missed or a dismissed breast lump is probably the most common cause of litigation in the US because it's so easy to do a mammogram or a screening tool and say, well, that must be nothing. Mm-hmm. But we have to remember that a screening tool is meant to identify things that you don't notice that need further investigations. If you have something that you have noticed, you need a diagnostic assessment. And a diagnostic assessment is a mammogram with an ultrasound. And when those things are put together, then we typically will report that we haven't seen anything else, reconnect with your family physician. If they remain concerned, then they'll refer to us and we can do a biopsy or we can assess it further.
It's something that, patients that I think miss often if they don't think they're due for a mammogram. Let's say they had one in the last 2 years and they feel a lump, they think, well, I've been cleared. No, that's not the case. So, like, if
That's right.
just the same way that if someone has new rectal bleeding and they had a colonoscopy 5 years ago and they're not due for a colonoscopy yet, we don't just dismiss it as nothing because they're up to date on their screening. So yeah, so breast lump, absolutely see your family doctor. If you don't have one, obviously walk in clinic or wherever you need to go. And then the process for women in terms of again, most diagnostic assessments being done at St. Joe's here in London. Would you
I would
say?
say yes, that's
Yeah.
right.
And then again, what should women expect at that appointment? So again, they get the imaging done. I've had some women, be offered a biopsy at the time, some delayed. Is there any rhyme or reason for that? Or
Not really. I
okay,
think that ideally we would like to minimize the repeated visits. And so we were making an effort to do everything on the same day. If we see an abnormality on the mammogram, have the radiologist report it right then so that we can take you right away for the assessment part, which is the ultrasound,
mhm,
plus or minus the biopsy, and get that story going. I think that we have to tailor that approach. For some people, that is really anxiety provoking and too overwhelming.
sure.
And if they don't have family with them, if they're not prepared, if they're just coming between work breaks, it's not okay to do that to someone. And so we have nurse navigators there that try to help understand that piece. For some people, convenience or travel is a big issue. If you're traveling hours for your assessment, we'll try to expedite everything same day. But it doesn't mean necessarily that it's more scary than if you get called back for a second look ultrasound and then a biopsy scheduled after that. I think that we worry as soon as a biopsy happens, or if it's happening too fast, that actually it means something necessarily is bad. And that's not true. The majority of the biopsies end up showing not cancer, that are actually benign, and a portion of those will end up being cancer. And the coordination of that is really tailored in an effort to be convenient to the patient. Either way, that gets resolved, diagnosed, and then gets referred automatically to the surgeons at the breast clinic.
For women who do notice a lump, who get imaging done and show something benign on imaging and reassuring, obviously nothing further to do. For those who feel something and have imaging that shows, let's say, nothing, like there's nothing to explain that lump that they showed. What is typically the follow at that point? I've been seeing in some reports that are being sent to us a citation to a study saying that that there I think thousands of women that were studied, and extremely few of them ended up having something concerning. Can you tell us a little bit about that? So again, women with palpable lumps and again, nothing on imaging, kind of what next steps
Mhm.
should be.
We've tried to make this whole process a little bit easier when we get a referral for someone that has a concern, and we do the mammogram and the ultrasound. When done together at a dedicated center, it's like at least 99% sensitive to detect something if something exists. And therefore we feel really reassured if they're both negative, that there isn't anything obvious that we need to intervene on. And so if they have a family doctor, we include in that note back to the family doctor that we're not going to automatically book a surgical appointment, but re-examine your patient. If you remain concerned, we value that information, let us know, because it
Yep.
occasionally, in those rarest less than 1% of the time, there is something that the mammogram and the ultrasound together didn't identify. You
Yep.
remain concerned. You can still feel something.
Yep.
No, but most of the time you felt that it was nothing, and the imaging confirms that, and that together puts the story enough to reassure the patient. And then in that case, we don't do anything else. But if you remain concerned, we want to see them again, and then we take it further to biopsy or an MRI or something like that. But that is really, really rare.
We're going to take a quick break and be back right after this message. And we're back. Again, we're joined today by Dr. Muriel Brackstone. She's a breast surgical oncologist here in London. So, Dr. Brackstone, we'll jump into kind of the unfortunate situations where a woman does have a biopsy done and it does end up showing breast cancer. These ones obviously are often seen by yourself as a surgeon. Um, Tell us a little bit about kind of what those conversations are like for you and the patient. What are things that determine kind of where the patient goes in terms of surgery, chemotherapy, radiation, and kind of things for women to know? Obviously, thankfully, most women will not end up in the situation of getting breast cancer. But for those who are, what are some things that they should expect along that journey?
Well, I think the first reaction, the knee-jerk reaction of every patient is just to come in the clinic and say, I just want them both off. I want a double mastectomy. I just want to live. I want to raise my kids. And the first conversation is around the surgical treatment and realizing that as long as you have a normal amount of gland around the lump, and we can take the lump and leave you with a cosmetically pleasing breast, there's no survival difference between taking the whole breast off and taking the lump itself. And so if we're doing things out of fear, we want to be sort of evidence-based to say, actually, when we can do that, but it's not going to impact on what you really want, which is the survival. The impact on survival is going to be really driven by other treatments to reduce the risk of it coming back somewhere else. So the local treatment you can get rid of. And even if we have to do a mastectomy, we now offer for everyone who's a candidate immediate reconstruction with a plastic surgeon. So we can work all of that together in a timely way without significant delay. But in some patients, if they have what we call high-risk cancer, so it's already spread to the lymph nodes under the armpit, is the first place before it goes somewhere else, or the cells are fast growing. So we look at grade, how fast they grow. We look at whether they eat estrogen and progesterone for food, if they're hormone sensitive, or if they have this protein called HER2. And when they're fast growing, they're not responsive to hormones or they're HER2 positive, the best way to kill that quickly and make sure that it doesn't go anywhere else is to take chemotherapy. And people are scared of that. It makes you lose your hair. It's IV once every few weeks, usually spread out over 4 or 5 months. But particularly in young women, doing that first is the best way for us to gauge that it's working, because it'll melt that cancer to nothing. And those people have a great response, have a great long-term outcome. And so often we'll do that hard thing first, and then tidy up whatever's left, and then add some radiation, which now typically we'll do once a day for 5 days over a period of 1 week, where we used to spread it out over 5 to 6 weeks. And that'll give you a square sunburn. Afterwards, if it is a hormone sensitive cancer, we'll typically add an anti-estrogen tablet that you take for 5 to 10 years, depending. Most of the postmenopausal women, even if there is a little bit in the lymph nodes, we typically, I think, historically overtreated people with chemo. And now we have some tests called an oncotype test, where we can actually look at what is the risk of it coming back. And if the risk is low or medium, we don't need to add chemo. We just do the surgery, radiation, and an estrogen blocking tablet, and it's become a lot easier. So it's not as scary as it feels coming in the first day of consult.
A couple of the questions I wanted to raise you, again, kind of stepping back to women presenting with symptoms, again, not necessarily those not with breast cancer, but just women presenting to our clinic, and related to the nipple specifically. We'll have patients coming in with concerns about rashes around the nipple, or nipple discharge, or bloody discharge. Again, when should they be seeing their doctor? What kind of symptoms related to the nipple would you say are ones that really should be going to their doctor?
I think the best held secret is that most women, particularly those who've had pregnancies or have had children, if they squeeze their nipple, they can get some fluid out. It doesn't matter the color. It could be blood tinge, it can be oil looking, it can be clear or white. And if it's induced, in other words, you can squeeze the nipple and some fluid comes out, that's pretty normal. And we're not fussed about that at all. And I think where people get worried is they check to see, is it still reproducible? It's still coming, and actually probably induces more fluid production, and you actually perpetuate this nipple discharge, and then it becomes a little bloody because you're compressing the duct, cause a little bit of damage, and then you get really worried. Regardless of the color, we're really not worried at all about induced discharge. The only time it's a concern is if it's spontaneous. In other words, you're doing nothing and the nipple starts to leak. And if that's happening across both breasts, then we think maybe it's an endocrine problem. Maybe we should check your thyroid, your parathyroid, your pituitary hormone levels. If it's happening in one breast or one duct, then maybe there is something wrong that's spontaneously leaking. 95% of the time, it's a papilloma, a benign polyp of the milk duct, which we treat by cutting it out. Rarely, it's just some dilated ducts that just collect a bunch of debris and junk, and it occasionally just spills out. Then we can also make a little surgery, a little incision, and just cut those ducts so it doesn't do that anymore. But it's really rare for any of those scenarios to actually be a cancer. The best way to make sure is just to do a mammogram as part of your assessment, because if anything, we think it's going to be the precancer, which shows best by calcium flex on the mammogram. The only other thing with nipple rash is it's typically on the nipple head itself, not on the areola. And if that nipple looks raw or eczematous, it's got like a raw surface to it, and that's a new change, that we want to see. But that's a really rare change that we call Paget's disease of the nipple. It's really not common.
Thanks for all the super helpful information, and a lot of food for thought for women, a lot of helpful information about screening and breast cancer, and kind of what women should expect to going through the process. So again, thanks so much for joining us today.
My pleasure.
Thanks again to Dr. Brackstone for joining us and for all the helpful tips. So again, to review a few of the things that I really want women to take away from this. If you are between ages 50 and 75 and average risk, meaning no first degree family member with breast cancer, it is important to be getting a mammogram every 2 years. So make sure we don't fall behind on that. As of next year, the age will change from 40 to 75. If you do have a first degree relative with breast cancer, making sure you get that mammogram done every year. And again, at age 75, having a chat with your primary care physician, if you do have one, about pros and cons of continuing screening after that. And if you present with a new breast lump that you notice, please don't hesitate to reach out to your family doctor right away. And you'll get examined, and decisions will be made in terms of kind of next steps for investigation. So don't ignore breast lumps. And until next time, stay healthy.